Hey, thanks so much for joining us today. We're really glad that you're joining us for GM Insights, and we have a treat. Twice a year, we have somebody from outside the state of Georgia whose expertise it just gives us an opportunity to see what's happening elsewhere. And Dr. Heather Schickedanz is going to talk today about staff training to use the Mini-Cog as part of cognitive screening at check-in. She is a family physician geriatrician who serves the LA County Department of Health since 2015. She's an associate professor of family medicine at the UCLA Geffen School of Medicine and served as chair of the Department of Harbor UCLA Family Medicine since 2018. I'm so glad that she's joined us. We've had her here in Georgia once before for a summit, and so glad to have you back. We'll go through some of the disclosure slides and just wanted to point out that we're interested in your feedback. And so if you want to capture a QR code here, anything that you want to suggest about future topics, we'd be glad to hear about as well. Let's go to the next slide, please. The topic today, training your staff to implement the Mini-Cog. There are a couple of disclosure slides that we'll just sort of hop through because there are no relevant disclosures. That's the first absence of disclosure slide. Here's the next one. Great. And Dr. Schickedanz, we're going to turn it over to you and let you take it from there. Thanks so much for joining us.
Hi, everybody. Thank you so much for having me. This is a real pleasure. Just give me a thumbs up if you can hear me. Great. Well, thank you for joining and taking time over your lunch. I'm Heather Schickedanz, and I'm really excited to be with you, although I wish I could be with you in person in Georgia. That would be much more fun. I would like to go over some of our goals for our time together, and I'll say that my number one goal, besides what I'm going to put on the screen, is that you all feel like you're a little bit more familiar and comfortable with approaching something like the Mini-Cog to start screening for dementia if you're not already doing so in your primary care space. So my first goal, if you don't mind clicking for me, Emma, I'd like to share how our large public health system in Los Angeles launched a multi-domain training initiative, fancy way of saying lots of different ways we did our training, to prepare our primary care teams across the county to implement annual screening for cognitive impairment for all adults aged 65 and older, and we chose to use the Mini-Cog. Next. And I'd also like to share some insights and tools with you all to be able to implement team-based training for the Mini-Cog to share with your clinical staff. Next. And finally, I'd like to describe some cultural considerations for providing effective cognitive screening and care in diverse populations, like the ones that we serve in Georgia and California. Next slide. So let's start with a case. This case, next please, is Miss Sanchez. She's a 68-year-old woman presenting for chronic care. Next. She is, her past medical history includes type 2 diabetes with an A1C of 8.5%, hypertension, hyperlipidemia, and history of a right-sided stroke with left upper extremity deficit. She's here with her daughter, who is her caregiver, and reports no concerns. Next. And she has never been screened for cognitive impairment and does not have a diagnosis of dementia. So just a case to sort of put in your head, maybe something like this that you see frequently in your own setting, where you have a patient coming in for sort of chronic care, but there's several things to address. Next. So as you're thinking about this talk and your reality of primary care, what worries you most about screening for cognitive impairment in primary care? We're going to launch a little poll. Is it the lack of workforce training and preparation in your setting? Is it the usual suspect, time pressure and competing priorities? Or is it what to do with positive or abnormal results on the screening test? Or is it something completely different? I'll just give you a moment to go ahead and vote.
Votes are coming in. We've got over half of the people have voted already. We'll just give them a little bit more time and to see if we can get a more robust response, but we're getting really close.
Okay, great. Let's get out the vote.
Let's get out the vote and hang on. We're gonna show you the results in just 1 second.
Great.
Okay, and we're gonna close the polls and we've got 75% voting, which is better than in most counties.
Okay. Oh, this is so great. All right. Well, We're going to be talking about all of these things. So obviously the main goal for today is to talk about training, but we're also going to be talking about how to balance all of this with usual primary care and what to do with the results very briefly. Next slide. All right, so I'm going to zoom through a timeline. We have been working on this in LA County really with focus for the last year, but it's actually been about a decade of preparation for this launch. So we're just going to click through, Emma, a few of these time points. So starting in January 2011, that's actually when the Medicare annual wellness visit began, and that put cognitive screening on all of our radar. Um, in July of 2022, more than a decade later, Medicaid, which in California is Medi-Cal, Medicaid actually in our state launched something called Dementia Care Aware. And this is a Department of Healthcare Services initiative. And it actually brought equity to cognitive health screening so that our Medi-Cal patients also have annual cognitive screening in their annual visit. So it provided equity between Medicare and Medicaid. Between 2022 and 2024, we said, okay, we're supposed to do this for all of our Medi-Cal members, but how will we actually do this? So we had to do a lot of system transformation. We set up in our state a Dementia Care Aware Clinical Advisory Committee, which I served on, and several pilot sites across the state, several of which were in LA County, began a massive practice transformation and EHR redesign since this was not built into our workflows or our EHR. And certainly many of our staff had never been formally trained on how to do this. Once 2024, towards the end of the year, we actually took the show on the road, began doing sort of boot camps and trainings across the state in the form of mostly webinars to start to familiarize people. And I'm going to be sharing a bunch of resources that are free and have great CME available where you too can take a look at these webinars to get further training. And then starting in 2025 through current, we really went ahead and launched this new program in our EHR. It did take a while to redesign. We have Oracle, formerly known as Cerner. I don't know what system, which EHR you all use, but we had to really redesign the workflows and the screening tools in our EHR. And then we had to really flood the organization with knowledge of how to use these new workflows. We did more all-team webinars and also designated clinic champions and held office hours around the time that we launched our EHR tools so that everyone had a lot of support basically everywhere they turned, especially I would say in the actual clinic setting. I think that was key. Everyone's really busy. I do appreciate that you all are on this webinar. But in terms of staff training, it's really implementation that's the best teacher. We have been keeping this alive through 2026 with ongoing trainings, including an annual training that's built into our learning management system. And we also do a lot of role plays. So I think that my favorite thing to do is actually go to a staff meeting, and I've been to many across the state and the county, go to a staff meeting with a short presentation and most of the time dedicated to role plays, because there's nothing like pairing up with your colleague and practicing a cognitive health screening and Mini-Cog on each other and seeing what the results are, maybe, you know, before coffee, to really show people what this feels like, both as the administrator and also as the recipient of the cognitive health screening. So I want to leave you with that for sure, is that role plays is probably my favorite and most effective way of training your staff.
Dr.
We also have a,
Can I just ask you to elaborate
sure.
a little bit more on who is staff and which
Yes.
were the staff that you were working most closely with, and maybe just a piece about scope, because I think that's come up even in our morning conversation about your upcoming presentation today.
Yeah, that's great. And I'll get into that a little bit further in the presentation, but this is a great place to introduce it. So when I'm talking about staff, I'm actually talking about our nursing staff, which in our setting, in terms of the day-to-day clinic flow, is mostly medical assistants and LVNs. We have our RNs on the floor, but they're not really doing intake, vitalizing our patients, helping with various screenings like for depression, housing, and food insecurity. That's all done actually as part of our intake by our nursing staff that's sort of team lidded up with our providers. So that's actually who I'm talking about in terms of training to do the mini-cog. We have gone further than that, and we've trained other staff, such as our nursing care managers, our RN staff, as well as our social work teams, to be able to help us follow up on the abnormal results. So it's a full team based approach, but it really starts with intake. Okay, great question. Thank you. Um, I wanted to share that as of this year, we've also launched some further support for training and for providers, for physicians, which is a new cognitive impairment expected practice guideline to guide providers on next steps in brain health, as well as a geriatrics e-consult, so advice and sometimes appointment-based electronic consultation platform for providers who are struggling with either the workup or management of cognitive impairment. Great, thank you. Okay, next slide. So this is just really quick. I don't expect you or want you to even try to read this, but this just shares how California Department of Healthcare Services expanded the Medi-Cal benefit. And so far, we're holding on and hoping that this benefit continues because it does come with a very modest amount of funding. And by modest, I mean $29 per screen, but $29 per screen to do the screening for cognitive impairment in primary care. Next slide, please. So just briefly, what the mandate is for Medi-Cal is that we do an annual screen, just like we did for Medicare. And in our system, we are doing it with team-based care. So to answer Dr. Johnson's question, our nurse performs the annual CHS at intake, and this does, to be fair, add about 3 to 5 minutes. But it's only for our patients 65 and older. So in our system, that's only around 15%. But in different systems, that might be a much larger percentage of your primary care volume. It does take some extra time. The provider then reviews and attests the screening and takes any further history, makes a brain health plan, and coordinates follow-up. And just a caveat that can take several visits. This is not a one and done. And so, yeah, this is something that in primary care is a longitudinal process oftentimes. And referrals may include social work, behavioral health, and specialty care. So it's not just a screening. There's more. Next slide, please. All right, let's talk about the Mini-Cog. So this is our actual cognitive health screen. We have 3 parts. So the first part is the Mini-Cog, and you can see the paper version up here on the top right. And it's freely available. I have all the websites. There's multiple languages and lots of screening tools actually on the Mini-Cog website. We also use the functional activities questionnaire because we know that cognitive impairment plus functional decline is what actually denotes true, concern for a neurodegenerative process or a dementia process. So we couple the Mini-Cog with a functional activities questionnaire, and this is actually done as a laminated sheet that we hand to the patient or the caregiver, and they just answer yes or no as to whether they are independent in these basic activities and instrumental activities of daily living, if they're independent or if they need help. And I'll say as a primary care provider, this is gold because just knowing what people can and cannot do by themselves, where they're struggling, whether that's with things like paying bills or taking medications, those instrumental daily activities, or the basic activities really provides me a lot of information as to where they might need help to be able to thrive. The third part of our cognitive health screen in LA County is the recognition of a caregiver. It may or may not be their actual decision maker, healthcare proxy. In many cases, it is not the same person. We really want to know as we're doing this cognitive health screen, who's helping them with these functional activities or with these cognitive impairments that they're beginning to experience. And so we do identify the person that is most helpful for them, and then we use this as an opportunity to also provide information about advanced directives and caregiver support. Next slide, please. We did have to sort of make this a little bit less clunky. So before our EHR rollout between 2022 and 2024, while we were working with Oracle, we actually had a front and back piece of paper. I wanted to show you all this because this is like real life. It was a little messy, right? We had to actually print this out. And on one side, on the left, you can see we would have the surrogate decision maker name listed, their phone number. We would do their mental status exam, and this was actually the Mini-Cog sort of simplified for our medical assistants and LVNs to be able to use. I want to point out something, and I'm about to show you a video. So if you're feeling a little sleepy, we'll wake up with a video in a minute. On the left side, it says step 2 clock draw. I wish I had a pointer, but on the left, it says clock draw. And then in the middle, it says, or if patient is physically unable to draw a clock, or this is a phone visit, you can do the alternative step, which is an animal naming task. So for people who weren't able to hold a pen or couldn't see well, we would do the animal naming task as an alternate to the clock draw. Okay, and then we did the 3-word recall as part of the Mini-Cog, and I'm about to show you a video with all of this. So don't worry if you can't read it. Thank you for advancing the slides. This is what it looks like in our Cerner EHR. Lots of clicks, lots of boxes, very busy, but pretty fast once you get used to it. Next slide. I did want to take a moment. I don't know if we can do this smoothly with our technology, Emma, but I wanted to show you, I think it's really important. We have an all-team training SharePoint site. I don't know if you're able to click the link and open that up. But this has been hugely helpful for our staff. Oh, I hope it doesn't mess us up. Fingers crossed. I'll go ahead and describe what's on the SharePoint site. Basically, it's a one-stop shop, like a hub that we've used for training for the Mini-Cog and the other components of our cognitive health screening. It has links to videos. It has information about how to set up and do your own training using both shorter and longer webinars that we've created. And it has links to sort of what to do next. So if you encounter a positive screen or have a patient that has special needs for whom it's difficult to do the screen. I'm not sure if this is going to open, but I don't want to take too much time. Emma, do you want me to give it a minute?
It is not opening, unfortunately.
I am going to put the
I have
link
to.
I am going to put the link so that it's available to everybody, and then I'm going to try it on my own computer that's not broadcasting. And so I think this will be a useful resource that folks can get to, but they might not be able to see it live over our Zoom meeting.
Understood. And
Let's
if it
see.
doesn't work because of firewalls or such, I can provide that link so you can share it afterwards. On the right-hand side of this slide, you can see our adult cognitive health screening job aid. And I just wanted to point out that on the top, it says this job aid includes the workflows for the following. So A, ambulatory nursing, because in our system, as I mentioned, we've trained our nursing staff to do the Mini-Cog. B, ambulatory provider. The provider can also do the Mini-Cog and complete the cognitive health screening and is the person who is responsible for following up on that screening. And then C, our behavioral health integration staff. So that includes our social work, our community health workers. I just want to point out that the Mini-Cog can be implemented with, training, pretty brief training actually, can be implemented by any member of the healthcare team. It does not have to be done by a licensed provider. So we've actually trained community health workers in our setting to help with the Mini-Cog as well. So it's really an all hands on deck approach. Let's go to the next slide. Okay, so I wanted to share the site for Mini-Cog training because obviously it's not all going to fit into this webinar. If you just Google or whatever you use, sorry, not trying to sell Google here, but if you just go to Mini-Cog on your browser, it'll quickly pull up the Mini-Cog. This is a tool that was developed over 20 years ago to be used in primary care settings with low literacy population. So for us, this was the best tool. And I've been using the Mini-Cog training website for over a decade myself. We have adapted it together with working with Sue Borson. Dr. Borson is the creator of the Mini-Cog. We have adapted it to use in our setting and with our health record, but it's very minimal adaptations. And I shared the most important one, which is we needed an adaptation for the clock draw task, since not all of our patients are able to read and write. So that's one of the adaptations we made. But I highly encourage you to check out this website. It's fantastic, and it basically has everything that you might need to train yourself and your staff to use the Mini-Cog in primary care. Next slide, please. Okay, so here comes the video. This is my literally 5 minutes of fame. So across LA County, we've used this video and other videos to show staff in our own clinical setting what it looks like to implement the Mini-Cog in a primary care intake. And so this is a little different than what you'll find on the Mini-Cog website because we're showing it embedded, done by a nursing staff member, as if it was being done at the beginning of a primary care visit. So I wanted to take a precious 5 minutes of our talk to show you, because I think that this is sort of the best way to understand how we've implemented the Mini-Cog. So let's go ahead and hope that the video plays.
We may not have all 5 minutes to look, and so we'll see how far we get.
Okay, that's fine.
While we're waiting to see if that loads up, I do have a question in the Q&A box that I can offer for you, and that's
Great.
from Deborah Arnold. Thanks for this question. Is there any, how do you do outreach in order to get the functional activities questionnaire completed if and when the patient who comes by themselves?
Wow, that's a fantastic question. Thank you for that. It is difficult. There are other opportunities that we can leverage to try to get that done. So one of the ways that we can do that is by setting up a follow-up appointment that is a telehealth visit. Oftentimes, if we can't complete all of the screening or if we need more collateral information from, say, a caregiver, which is probably what you're alluding to, if the patient comes by themselves, and maybe they're not the best historian, or they might not have the most insight as to what is really going on in the home, we can offer a telehealth visit and say, hey, you know, we'd really like to get more information about how you're doing at home on these different activities of daily living. Can we set up a telehealth visit and include your caregiver? We're able to do that even in a three-way setting, so we can bring in a caregiver if they're, say, not in the home. But that's how I've tended to approach it. We can also mail it to them, which is a little bit more clunky, but there are these asynchronous ways to obtain the information.
That's a great answer. Just watching, yeah, the video won't load because of a firewall. I had some of the same problems in terms of getting the LA County training video to load, but that's okay. We'll work through that. If I could just ask a couple of questions, and then we'll go to following up on our case, which is item number 17. In terms of, as you train other people to do work at intake, sometimes it's moving work from one person or one group of folks to another. And so what were some of your experiences in training staff? Did they like the work? Did they find it engaging? Did they feel it was valuable? Perhaps you could tell, because you have a lot of experience in doing this and want to make sure that that comes across.
Yeah, thank you. I'll say that the handoffs and information sharing between the different staff members who are involved in this process are key. So starting off with a teamlet approach, I wanted to start from the beginning of a clinic session, if that's okay. We encourage staff to huddle with their provider to review the schedule for the day. We identify the patients who are 65 and older on the schedule for the day and say, you know, is this patient somebody who's already been diagnosed with cognitive impairment or dementia, in which case do not do the screening. And our electronic health record helps us with that as well. It doesn't fire sort of the recommendation to do it if the person already has the diagnosis. But if they are due for their annual screening, the staff is encouraged to complete that at intake. If the patient declines, that's okay. And we encourage the staff to let the provider know that the patient has declined the screening. And in many cases, when that does happen, it's appropriate. The person is in a lot of pain, they're feeling very sick. It's not the best day to do a cognitive screen, and that's totally okay. The way that we encourage communication is obviously, first and foremost face to face. But once the clinic session gets busy, as you all know, it's sometimes really hard to have those little mini huddles. So if we can't have a mini huddle, we use what's called a sticky board. We have the opportunity in our electronic health record to add a sticky note to the ambulatory organizer, and it's just an electronic note that says whatever it says: patient declined screening, or patient hard of hearing, doesn't have hearing aids, we can't do this today, caregiver's not present, patient is confused, any kind of communication that the staff needs to place. And then we also use a real-time messaging app on Teams, our secure messaging app. So we also are sending sort of like what looks like text messages between the provider and the CMA, our nursing staff, during the session. So I will say that most of the time, none of this needs to happen. Most of the time, the staff does the screening. It's done. It's there. I see it. I review it, and I take it from there. But when there's a communication needed, um, and I'll just say one more thing. If there's an abnormal result, and this is what I was hoping we would see on the video, if there's an abnormal result, we have a lot of training on how the staff can acknowledge that with the patient in real time without giving them any sort of diagnosis of dementia, right? That was one of the biggest training pearls, is that staff are really worried, and this is understandable. Hey, I'm doing this quick screen. The person isn't necessarily anticipating that we're going to do this today. They might not even have this on their radar at all. What if it's abnormal and the person is sort of like upset, and that happens? What we've trained our staff to do is really normalize that we're doing this screening for everyone, and it is not a diagnostic tool. It's just a tool that gives us a little bit more data, more information about what might be going on today. Because again, we might have an abnormal screen that reflects a person's current state, but not their baseline state, right? So it's really important for staff to normalize that we're doing this for everybody once a year, and that the information will be reviewed further with the provider, and that it's not a diagnosis of dementia. And so we've had to do a lot of training around that. And I'll say that the first couple of months, there were some bumps in the road. That's why I mentioned we had a warm line to sort of phone a friend, which was like me and the other geriatricians in our system. There's not a lot of us, so we sort of spread ourselves out with these office hours and clinic champions to be able to address real-time concerns. And those concerns have really waned. I think staff are much more comfortable. I will say we're doing this across over 30 clinics, and we're doing hundreds of these every day now. And so it's just getting the practice and the comfort with it that's helped our staff feel more comfortable raising issues with the providers directly, and not necessarily leaning on the geriatricians in the system.
I've got one other question, if I could go to that, and this is from Dr. Anna Merck, who's practices over at the VA, a geriatrician who's our fellowship program director. This is about your false negative situation. I've seen patients with subjective cognitive concerns who are then told they're fine because they have a normal Mini-Cog. What are your thoughts on these situations? What's the workflow that you do when someone's Mini-Cog checks out just fine, but there's more to the story? Thanks.
That's a great question. So oftentimes, if patients do have cognitive complaints, we've trained providers in particular for this. We're not going to use the basic, Mini-Cog screening tool. We're actually going to go to a more comprehensive mental status exam. In our system, we use the RUDA, the Roland University Dementia Scale, but we also have access to the MoCA, the Mini Mental. So there's various tools out there, which, as many of you know, are longer. They're 30 items. They do take longer, around 10 minutes, 10 to 15 minutes to complete. But in the case that the patient has a subjective cognitive complaint, or their caregiver has a complaint, we actually don't rely on the Mini-Cog at all. Mini-Cog is a fairly robust screening tool, but just like any screening tool, it's going to miss some patients. It doesn't have 100% sensitivity or specificity. So we do encourage the mental status exam in those situations. Thank you for that question.
Great. Let's go ahead and go to your returning to our case slide, which is slide number 17, and we'll let you
Okay.
take a couple of minutes to wrap up from there.
Okay,
And
great.
I'll continue to watch for other questions too.
Thank you for the questions, everyone. I really appreciate them. Okay, so we can go to the next slide. I think it
That
was
would be
returning
slide
to our,
19. I'm sorry, it was slide 17 on the deck I'm looking at. Thank you.
there we go. Okay, so returning to our case, and the video, I apologize it didn't work. I was hoping that it would, but uh, so the video was of this screening intake, or the Mini-Cog being implemented at screening. So returning to our case, the patient actually did score abnormally. She was unable to do the clock draw because she's left-handed and couldn't hold the pen after her stroke. So they actually pivoted and did an animal naming task. She was only able to remember two of the three words of the Mini-Cog, and she was not able to name the animals for the animal naming task. So she actually scored abnormally, and the video shows how the medical assistant in this case sort of handled that and models how to share that information with the patient and the caregiver, as well as getting the caregiver to, in parallel with the Mini-Cog, the caregiver is filling out the functional activities. So that's how we make it a little bit more efficient in our system. If we have a caregiver present, we have them, with the patient's permission, fill out the functional status screener while the patient is doing the Mini-Cog with the medical assistant. So how might this look different if the patient needed a Spanish language interpreter, or another language interpreter? I want to address this because it's so common in LA County, and it's probably fairly common for you all too. It does make it look a little different. So, because on one hand, the patient is often a bit confused, having to go between the interpreter and the person who's administering the Mini-Cog. Sometimes it takes longer. And what we've done in our training is we've actually reminded staff that this is not a study. This is not a clinical trial. We're trying to do this the best we can with the limitations in our system or the barriers that we may face. And at the end of the day, if the screening can't be done, that is okay. If there are cognitive concerns or if there are other modalities that need to be used, that can be done by the provider. So that doesn't have to be something that sort of takes extra time and causes a lot of extra stress on our nursing staff. But we do encourage the use of the healthcare interpreters. And we do say it's okay if it takes a little bit longer and it's not like perfectly to fidelity with the Mini-Cog sort of, done in a petri dish. So I wanted to share that. I'm happy to take any questions about how we've navigated the use of interpreters for implementing the Mini-Cog. We also often have patients that have several acute concerns. And in those cases, if there's not enough time to that poll question, like, are you worried about time and competing priorities? If there's not enough time to do this properly, we say don't do it, okay? Because we don't want to do this if the person is in pain, is feeling ill, is feeling really stressed out, frankly, or if the provider is behind. We're not going to do this screening test if we're not going to do it well, and it's going to just cause everybody a lot of stress, because then we won't be able to even really trust the results. So we've sort of taken our pressure off the system, and I think that's been really helpful. It's a
I'm sorry, could we go to your thank you slide and then give folks a chance to evaluate as well? And I've got one
Oh, sure.
person who has a hand up and I'm going to allow her to talk for further questions.
Yes, I'm sorry. And I'm
It's okay,
sorry,
you're doing great.
is this supposed to be over?
At 12:30, yep. Okay,
Okay,
yep,
thank you.
we're doing great. And
Okay, thank you.
Latifat, I'm going to ask you to unmute and you can ask your question.
Yes, I just wanted to ask, can you hear me?
Yes, we can
Yes,
hear
I
you
can.
just fine. Go ahead.
I just wanted to ask, so the links that we could not see, is that going to be sent to an email?
Well,
Can we get
we're
that in
gonna-
an email form?
Yeah, thanks so much for that question. We're going to work with Dr. Schickedanz to figure out how we can get permission to access some of those. There were two that I couldn't get, one that Emma couldn't get, but I know that those are really important and would be valuable. So we'll work with that. So thanks so much.
Thank you.
Okay. And And then if we could show the, yep, let's do this quick poll for folks attending.
Oh.
Great, thanks so much. Give you just a couple more seconds to do that. All right, thanks so much. And then let's show the slide for credit. And then thanks so much for your evaluation of the event. We really appreciate our earlier morning guest from California coming in and talking to us at our lunchtime. And so thanks so much for that. And we will go ahead and close our session. I'll ask the panelists to stay on for a second.